Okay.
So, with all your permission, we are getting started with the session, everyone. Good evening, one and all present here. I am Monalisa from Clirnet, the designated session assistant to ensure a seamless interaction. And Clirnet proudly stands as India's premier digital platform tailored for doctors, providing a wide array of invaluable services. Clirnet is elated to be chosen as a digital partner for this event organized by Oncology Integrated Society. Welcomes you to the webinar on management of oral cancer. So, thank you for your patient listening, everyone. Let us get started with today's session, for which I would like to call upon Dr. Deepti ma'am to take the session forward. Over to you, ma'am.
Okay, thank you so much. Hello and welcome all the participants and the delegates, speakers, chairpersons to this next episode of Cancer Webinar Series. Yes, it is a matter of great honor and proud privilege to host this webinar from the aegis of Onco Integrated Society with support of Dr. Chaturvedi Cancer Hospital and Team Clirnet. Today, we have a very learned speaker with us from Max Hospital, Delhi, Dr. Dodul Mondal, who will be talking on the management of oral cancers. He is very experienced and very well qualified, and he has been to many hospitals in Delhi. With him, we also have an equally qualified chairperson, Dr. A.K. Chaturvedi, a senior oncologist and owner of Dr. Chaturvedi Cancer Hospital, with a record experience of treating cancer patients of about 40 years, and who has also been past president UPAROI and had extra trainings abroad and has many awards and publications to his credit. Questions can be put in the chat box so that they will be discussed and answered at the end of the meet. And now, before beginning the session, I would like to call upon our dignitaries for lighting of the lamp and remembering God and goddesses of knowledge who takes away all the ignorance of darkness and illuminates our path with the brilliance of knowledge. Welcome all for the lighting of lamp. Yes, Clirnet team, go ahead with lighting of the lamp. Any problem?
Just a moment, ma'am.
Yes, now I would like to call upon Dr. A.K. Chaturvedi to take the chair and introduce the topic and the speaker. Yes, please take the dais. Your voice is muted. Muted hai, aap muted hai.
Thank you, Dr. Deepti, for inviting me as a chairperson. Today's topic is very important. It's oral malignancies. And this is really very important topic because it causes over 12,250 deaths. That means nearly one person per hour. nearly 58,500 newly diagnosed individuals. Out of these, only slightly more than 50% they are alive after 5 years. So this is really very important malignancy, and the survival number at 5 years from the diagnosis was for many decades about 50 to 57% only improvement over last 10 years. However, this is due to because of increase in HPV infections, use of tobaccos, etc., and certain other causes. Oral cancer is hazardous because in its early stage, it may not be noticed by the patient as it can frequently prosper without producing any pain or symptoms because the people are taking tobacco and the pain is and ulcer is hidden under that chewing tobacco they are putting inside the mouth between the lips and alveolus, buccal mucosa and alveolus. So the ulcer caused by the disease, they may not be knowing it. And when they consult some doctor for slight ailment, doctor says that, look, you have to stop the tobacco. And once they stop the tobacco, they are able to see the ulcer and the pain comes. So this might be one of the reason. So now this has become another thing is about 20% of these cases from the day one of primary malignancy, there are chances of developing secondary malignancy over a period of 5 to 10 years. And the HPV 16 virus and smoke, tobacco chewing, they are the main culprit. And these are the preventable cancers which can be prevented easily with the education and treated properly with the proper treatment. So today we are going to discuss on oral malignancies. And for that, we have invited our learned speaker, Dr. Dodul Mondal. He is Director of Radiation Oncology, Max Super Specialty Hospital, Saket, Delhi. He did his MBBS with gold medal, MD Radiation Oncology, DNB Radiation Oncology, UICC Fellowship in USA, Fellowship in Precision Radiation Oncology and Proton Beam Therapy, US. He has got wide experience and he was consultant in radiation oncology in Apollo Hospital, New Delhi. He was assistant professor in NCI AIMS, Delhi, consultant in Dharamshila Nayan Hospital. He was senior research associate school job. He has got many awards and papers of publication to his credit. His expertise is in proton beam therapy, head and neck cancer, neuro-oncology, pediatric malignancies, musculoskeletal malignancies. He has got membership of ICRO, membership of National Academy of Medical Sciences of India, member of ISTRO, member of ASTRO, member of American Brachytherapy Society, member of Association of Radiation Oncologists of India, member of Indian Society of Oncology, and other societies. At present, he is located at Max Super Specialty Hospital, Saket. So now I invite you, Dr. Mondal, for your expert comments and presentation. Dr. Mondal.
Thank you so much, sir. Thank you so much. And thank you so much, sir and ma'am, both of you, for this nice opportunity and this honor. It's always a great pleasure to be here on your platform, which discusses only academics, and your interest and enthusiasm about spreading knowledge and academics is really, really heartwarming. So, because we are already 10 past 8, so I would like to start my presentation, and I'll also keep my videos switched off during this time. So I would thank you again for nicely introducing about oral cancer and its important. So I am going to discuss about the management of oral cancer, and my main purpose of this presentation was mainly for the residents in oncology, radiation, surgical, and medical oncology, although the part of medical oncology is a little bit limited in oral cancer. So this is in short what I am going to discuss, and I'll try to finish my presentation in around 40 minutes time so that we can have some time for necessary discussion or answering some questions if there is any. So why do we need to discuss about oral cancer? Because this is one of the commonest malignancy in the world, and this is the second commonest among men in India. Tobacco is the most common causative factor and agent worldwide. However, in other countries, HPV is also an important reason. In countries particularly where usage of tobacco or in its different form are not so common. Surprisingly, as per this 2017 publication, in contrast to the oropharyngeal cancer, Indian population with oral cancer has a higher HPV positivity than Western or global incidence. Now, as you rightly mentioned, we can see here that oral cavity cancer, if we see the Globocon 2020, then we can see that the number of new cases in 2020 was 3,77,000, of which 1,77,000 died. So it's a malignancy causing high mortality. Now, if we see the scenario in India, then we can see that lip and oral cavity tumors, they constitute 10% of the total number of cancers, including both men and women. Now, if we see in the male population, we can see that as an individual entity, they constitute approximately 16%, being the commonest cancer in this population. However, in women, this is not so common, and it constitutes only about 4.6%. Now, if we see at the number, then we can see that 1,30,000, so the number of coming to this oral malignancy, I'm skipping the overall malignancy part. So if we see that the total number of lip and oral cancer in 2020 was almost 1,36,000, and the number of deaths in the same period was 75,000. That means almost 40 to 45% of the population actually die of this disease. The major reason of such dismal outcome, even with so much of advancement in the field of science, technology, and oncology, is late diagnosis. So we need to increase the awareness so that early diagnosis, early treatment, and better outcome can be expected. Now, whenever we talk about oral cancer, this is the basic anatomy we must know, that what are the subsites of oral cancer, oral cavity, and how about their lymphatic drainage. So that's the main important thing as oncologist. So oral cavity typically are divided into 6 sub anatomical region: floor of mouth, tongue, cheek mucosa, upper and lower gum, retromolar trigon or RMT, and hard palate. Now, if we see the lymphatic drainage, then we can see that oral cavity has a rich lymphatic drainage, and the tumors located anteriorly, they are having more common drainage pattern to submental, submandibular, and upper jugular-digastric lymph nodes. The tumors located posteriorly, they are having a common distribution lymphatic spread to the jugular-digastric lymph nodes and lower neck nodes. A little bit about the staging. So the first AJCC staging, which was published in 1972, was very interesting to see that the initial staging of oral cancer was also based on the size of the tumor. So T1 was like 2 centimeter or less, T2 was from 2 to 4 centimeter. Interestingly, we see that in oral tongue, involvement of half of the tongue or more than half of the tongue and involvement of tongue cancer with floor of mouth actually changed the stage. Now, after 45 years, in 2017, AJCC published its latest staging system where they have incorporated depth of infiltration as an important and significant component for the staging purpose. Now here we can see that T1 tumor is now 2 centimeter or less with a depth of infiltration less than equals to 5 millimeter. Any tumor which is having a depth of infiltration of 5 to 10 millimeter and 2 centimeter or less in size, they become T2. or a tumor which is 2 centimeter or more and less than equals to 4 centimeter with a depth of infiltration less than equals to 10 millimeter. That also becomes T2. Tumor with more than 4 centimeter size or any size with DOI more than 10 millimeter, that becomes T3. T4A and T4B are advanced form of the tumor. T4A is when the tumor is involving the immediate surrounding structures like cortical bone, maxillary sinus, or skin of the face. And T4B is when it infiltrates the masticator space, pterygoid plate, skull base, or it encases the internal carotid artery. Regarding nodal staging, so it divided into clinical and pathological stage, N1 to N3B. And here we can see that extracapsular extension has a significant role in changing the stage of the nodes. So presence of extracapsular extension upstages the nodal staging by 1. Now, it's very important to know how to evaluate a patient having to suspected to have oral cancer. And as you all know that a proper history and good general physical examination have no replacement. We need to know the symptom, the kind of problem the patient has, which will indicate about uh, some significant or important structural involvement like pterygoid plates, like pterygoid muscles, or floor of mouth. So so taking a good history to understand possible clinical stage is very important. We also need to examine the neck nodes properly so that we can differentiate between clinical N1, N2, and N3. Understanding how to examine neck node for identifying clinical N3B is also very important. A biopsy to have a proper diagnosis, which should be either incisional biopsy or a punch biopsy, is important. Fiber optic laryngoscopy or DLscopy as per the clinical indication to rule out deeper structures of the oropharynx or laryngopharynx or larynx. Staging and metastatic workup, which might include axial like CT scan, MRI, or even PET CT scan nowadays. Proper dental evaluation and speech and swallowing evaluation is also important before surgery and before radiation, and also in the follow-up period. Fertility counseling in young fertile group. And it's very important to understand that a multidisciplinary tumor board discussion has no replacement in oncology. There are studies to prove that the final outcome, that means in terms of overall survival, patients who were discussed in a multidisciplinary tumor board did much better compared to the patients who were not decided or not discussed in multidisciplinary tumor board. That means a person deciding alone about a case sometimes gives inferior outcome than multidisciplinary tumor board discussion and decision. So in oncology, it's not about one man show or one person's show. It has to be a teamwork. And in oral cancer or in head and neck cancer, the team must consist of dedicated dysphagia assessment team and rehabilitation team. So what kind of biopsy? Do we need to have a FNAC or what? So this is a systematic review of oral biopsies, what different types of sampling. And this systematic review undoubtedly says that surgical biopsy, either incisional or a punch biopsy, is the best to have better outcome. And this is most accurate form for assessment. And in case of lymph node sampling for a surgically staged patient, at least 18 or more lymph nodes should be adequately dissected and harvested from the pathology specimen. Coming about role of imaging. So imaging is important to stage the tumor properly, to understand the extent of the tumor, which are the structures which are involved. So that will guide us to know the resectability. And then if the patient is resectable, planning surgical excision. If the patient is not resectable, then planning radiation properly, deciding about the volumes of radiation. So all these things are very important, and these can be decided based on the different types of imaging and their findings. What kind of response if the patient has received some kind of neoadjuvant chemotherapy in borderline resectable cancer, so that the patient has good response, borderline resectable tumor became operable or not, restaging. Imaging is also very important in modern days radiation planning, because nowadays all radiation plans are mostly dependent on CT anatomy or MRI anatomy. and the concept of GTV, clinical target volume. So all these things are dependent on good quality imaging. Imaging is also important during the time of follow-up and its surveillance. And it's important to detect recurrence in its earliest phase. So imaging is definitely very, very crucial. So it's also important to understand what kind of imaging we're going to have, depending on the tumor, its stage, and perceived risk of systemic or distant metastasis. Imaging is also important to understand treatment-related side effects. It is very important in head and neck cancers because the post-operative changes and post-radiation changes, they create a lot of fibrosis, and these post-radiation changes and post-op changes sometimes create confusion between a suspected recurrence. So it is also very important to understand what kind of imaging we need at that point of time to differentiate a suspected recurrence versus post-treatment changes. Now, what is the best modality of imaging? There is no single answer. It depends on what kind of tumor we are dealing with, where is the location of the tumor, what is the stage, and what is the purpose of the imaging. Is the purpose just to rule out a metastatic disease, or the purpose is also to have more information about local extent and resectability? So that dictates what kind of imaging we are going to have. Like in this example, so I have shown that this very small buccal mucosal lesion, which can be very beautifully delineated in a puff-cheeked CT sequence. So in the background of the dark air, a small mucosal lesion can also be identified. For bony involvement, CT scan has superiority over other imaging like MRI. And in modern day surgical practice, in many advanced centers, 3D mapping of the bone before planning surgery and 3D reconstruction even before surgery show that the plastic and reconstructive team can plan the kind of flap they need to harvest, the way they need to shape the harvested free flap or fuller flap. So all these things are possible when you have a proper imaging. Now, MRI is very important in understanding local soft tissue anatomy and local soft tissue infiltration. So here we can see that this tumor has infiltrated and involved the masticator space. Here we can see that the tumor has also involved the pterygoid plates. We can see here that the tumor has encased the internal carotid artery. Another image where we can see that the internal carotid artery is encased. So all these things, now these things make the tumor mostly unresectable. So that is how an MRI is superior in delineating the soft tissue involvement. Now, MRI is not so good for detecting bony involvement, where CT has superiority, and CT is not definitely so good for having soft tissue information as MRI can give us. So here we can see that the MRI shows beautifully a tumor inside tongue. We can see here that the tumor has crossed the midline and reaching almost the opposite side. Here we can see that the tongue lesion is involving the masticator space and the floor of mouth. Here we can also see that the soft tissue of floor of mouth and the mandibular, the mental region is involved. MRI definitely, it's not that MRI cannot involve, cannot show us the bony involvement. So a negative information on MRI like or MRI not showing bone infiltration is mostly conclusive. So uh, again, we can see here how MRI can show us very small lesion of tongue. So here it was a less than 1 centimeter tumor, but on MRI we can see it very beautifully. FDG PET scan nowadays become very common, and being in our country, many centers are doing at a very cheaper cost. So it has nowadays almost become I'll not say fashion, but it's become a practice that almost all patients nowadays, after being diagnosed with cancer, they come to us with a whole body PET CT scan. Now, a PET CT scan has superiority over all other imaging in terms of detecting nodal metastasis and also distant metastasis. And of course, it can give us information about the local disease. So the superior is high, it has a high sensitivity for nodal and distant metastasis. In case of neck node with unknown primary, of course, we need a PET CT scan to detect some occult primary here and there. Tumors approaching midline, that also guides us about managing the contralateral neck. And many times we can detect contralateral neck nodes on PET CT scan. In case of definitive RT, we need to delineate the local nodal, the local regional nodes, and also we need to rule out metastatic disease in T3 or T4 primary, or in mode N1 or higher stage disease, to rule out metastatic disease again. Recurrent or persistent disease after treatment, this is very important. I'll come to this a couple of minutes later. It's a complementary modality for recurrent disease. So depending on perceived site of recurrence, an MRI may give more information on soft tissue recurrence or soft tissue involvement, and PET-CT can be complementary. So there is some NIRADS category or NIRADS scoring system. I'll discuss it later on. There is good evidence to suggest that a PET scan is probably more useful in response assessment between 3 to 6 months after finishing radiation. So this is for patients who has received radiation. A PET scan at 3 to 6 months can be maybe superior, and there are evidence to suggest that the patients who have been monitored by PET scan, they have better survival also, because they can detect recurrence or distant metastasis earlier. So this is a very beautiful study, and this article by Hisham Mehana, they have studied the role of PET-CT scan in treated patients, where the patients receiving radiation, they were divided into prophylactic nodal dissection after finishing radiation, and the other group were PET-CT based surveillance, where after treatment, if the PET scan did not show any residual tumor, they were put on just routine surveillance. So this was basically definitely treated patients with radiation, one group being managed with prophylactic neck node dissection, irrespective of the response, and the other group based on the PET scan response. So this showed that significant number of patients they could avoid prophylactic neck node dissection without compromising their outcome. So NIRADS, or neck imaging reporting and data system, this is for post-treatment surveillance, having categories 0 to 4, where category cells specifically focus on this category 3 and 4, where category 3 means new or enlarging primary mass or lymph node, a discrete nodule or mass with differential enhancement, and intense focal FDG uptake. So that means there is a high risk, high chance of recurrent disease, and an image-guided biopsy or clinical biopsies recommended with NIRADS 3 score. Definite recurrence is given a score of 4, where already a pathologically proven tumor, and further PET scan was done, or scan was done to assess the disease extent and ruling out metastatic disease. So this can be any imaging, like any axial scans, which can be a CT scan or MRI, and then PET scan can be combined with that. So this NIRAD scoring system is very, very useful in clinical decision making as well. A panoramic X-ray or OPG is very useful in evaluating the condition of mandible and the dental structures. This is very useful before mandibulotomy or mandibulectomy and pre-radiation evaluation to rule out infection in the socket. And if there is anything, then we can take care of that before starting radiation. Also, after radiation, to rule out the risk of to rule out presence of osteoradial necrosis. Now, coming to the treatment part, there are different treatment modalities for oral cancer. The main cornerstone of treatment is surgical resection. So surgery, radiation, which can include external beam radiation and brachytherapy both, and systemic therapy, which can include chemotherapy, targeted therapy, immunotherapy, and metronomic therapy. So this is the current NCCN guideline for managing oral cancers. And needless to say that all operable oral cancers, be T1, T2, T3, or T4A, they should be operated with proper margin and reconstruction if the defect is sufficiently big to cause disfigurement or functional morbidity. Then reconstruction is also recommended. And at the same time, addressing the neck depending on the stage and extent of clinical or radiological nodal disease, one can go for selective nodal dissection or radical node dissection. And after surgery, based on the risk factors in the final histopath report, patient can receive further adjuvant radiation or chemoradiation. Now, in early stage cancer or advanced stage cancer, wherever it is operable, surgery is the mainstay of treatment and the standard of care. And it is very important to understand that in resectable oral cancer, radical radiation is not the primary treatment. And even when I am a radiation oncologist, this is definitely my job also to counsel the patient that surgical resection followed by adjuvant treatment gives better outcome compared to radical radiation. And the different types of nodal dissections, as I said, it can be selective or MRND type 1, 2, or 3, or a radical neck dissection. There is no rule of observation of neck in case of oral cancer, and I will show you the landmark article where observation versus prophylactic nodal dissection was compared, and it was proven superior over observation alone. Brachytherapy has limited role in oral cancer for very early tumor, and it can be an interstitial implant, or in case of some superficial mucosal lesions like palate, we can also think about some kind of surface mold. So knowing a few facts about different types of flaps are also important. And we can classify the flaps based on their blood supply, based on the tissue type involved, based on the distance between the primary operative field and the site from where the flap was harvested, what kind of, whether it's a regional flap or not, and the local flaps. So most common in oral cancers in our center are a free flap or microvascular flap, which can be harvested from different sites, like it can be an ALT flap or anterolateral thigh flap. And after ALT, the most common flap which we see here are a free fibular graft, and latissimus dorsiflap when you need a bigger tissue. So depending on what kind of defect is expected, the reconstruction surgeon, they plan what kind of tissue they would harvest from which organ. Radial artery foramen preflap or RAF is also very commonly used in case of small defects. And pectoralis major myocutaneous flap where is another common type of flap, and it is mostly seen in centers where the facility for microvascular reconstruction is not available. So both these expertise and facilities should be available before attempting for this type of flaps. Now, as I was saying, is there a role of observation on not addressing neck in oral cancer? So this article from Tata Memorial Hospital in 2015, led by Dr. Anil De Cruz, this says very clearly that elective versus therapeutic neck dissection, there is no role of elective neck dissection. If we see the 3-year result, the group which were, so in this study, the patients were divided into 2 groups. One group after surgery of the surgery for the primary tumor, the neck was dissected prophylactically. The other group, the neck was not dissected, and the patients were put on stringent surveillance protocol by clinical examination, ultrasound of neck, and at the time of recurrence, the neck was dissected. So it was found that the patients who were prophylactically operated, they had a better disease-free survival and better overall survival also. So the study was terminated in between, and this is one of the significant and landmark studies after which the practice of not addressing the neck is now almost obsolete. There is excellent guideline from ASCO, which was published in 2019 for management of neck in squamous cell carcinoma. I'll not go through this article, but I'll request all the residents to download this article. This is freely available, and go through the recommendations. So in this article, only a very selective group of T1 disease with adequately imaging done, where neck nodes are not visible. So clinical and radiological N0, small T1 cancer, they are still considering neck to be, they said that neck still can be put under surveillance. Now, this is not a routine recommendation, and it happens in very rare situation where a very small tumor probably taken during biopsy, and the entire tumor was taken out with good margin. And then it was found to have a very small T1 tumor, and patient does not want to go for any further surgery, so one still can go ahead with this guideline. But of course, in this group of patient, regular surveillance with good clinical examination and imaging is mandatory. The patient has to be very, very motivated to continue a regular follow-up. If not, then one must go for completion surgery. There are some new surgical techniques which includes robotic. Uh, we all know about Da Vinci robot, and there are other so robotic surgery is something new in this field. People are using more and more for neck dissection and salvage dissection in oral cancer or oropharyngeal tumors, small oropharyngeal tumors. So introduction of robot has changed the landscape of surgery significantly. So the role of robot is probably much more in oropharyngeal tumor, where the straightforward recommendation of radiation has now been actually put under threat, and the quality of robotic surgery and the quality of life after such robotic surgeries are actually probably comparable. So introduction of robots, lasers, intraoperative nerve monitoring, and sentinel lymph node biopsy. So these are all new things in the surgical domain. So is there a role of revision surgery in margin positive case? So this is one of the commonly encountered situations in our setting. And many a times we found this thing to happen when the patient is initially managed by a center, a non-dedicated oncology center, and the tumor was resected, but the margin was not free. So does the patient need to go for a further revision surgery? So this article by Mustafa Bulbul throws a significant light on this. And they have mentioned that revision of margin does not change the final oncological outcome. So a patient having R0 resection at the beginning always does fair compared to the group who were initially R1 or R2. Now, even when the initial R1, R2 group is made R0 after frozen section and further revision surgery, their outcome is never comparable with an initial R0 resection. However, there is a trend of improved loco-regional free survival in patients who were initially R1 and converted to R0 after frozen section. Now, how much margin should be adequate? So traditionally, we take 5 millimeter as adequate margin, but this article from Canada, so this is from Canadian group, they have shown in this review article that probably 1 millimeter or more at the surgical margin or the inked margin is adequate. However, this should not be taken as standard of care as of now, because this is a review article, retrospective analysis, and we need much more studies or randomized studies in future to actually answer this question. So as of now, we still follow this 5 millimeter margin as adequate. Until the time we are having more and more robust data, that should be maintained. Now, for locally advanced oral cancer, again, surgery remains the standard of care for all operable patients. And on the histopathological report, we see whether such adverse factors are present or not. Now, what are the adverse factors we try to find out in a biopsy report? So these are extranodal extension, margin positivity, closed margin which are less than 5 millimeter, pathological T3 or T4 primary tumor, pathological N2 or N3 nodal disease in level 4 or 5, perineural invasion, vascular invasion, lymphatic invasion. So these are all different adverse pathological factors, and depending on what kind of adverse factors are present, we decide whether post-op radiation alone is sufficient or post-op radiation along with concurrent chemoradiation should be the choice. Now, these are two seminal articles where the role of adjuvant chemoradiation was established undoubtedly in case of margin positive disease and presence of extranodal extension, where it was shown that giving concurrent adjuvant radiation is provides overall survival benefit. And the role of chemotherapy in head and neck squamous cell cancer is analyzed on multiple times by this McKinsey group. And in the last updated analysis, they have shown that the benefit is actually limited to concomitant chemotherapy group, and the benefit 5-year absolute survival benefit is close to 6.5%. Notable to see that the 10-year benefit again stands tall, which is 3.6%. This article is our own, so this is from our own country, and Dr. Sarvani Ghosh Lashkar was the lead of this article, oral cancer adjuvant trial, where the patients were divided into 3 different groups. It's a phase 3 randomized controlled trial for advanced tumor, which were stage 3 and stage 4, presence of extracapsular extension, involvement of 2 or more regional lymph nodes, margin positive disease, extensive soft tissue and or skin infiltration requiring major reconstruction, presence of PNI or LVI, and the criteria said that the adjuvant treatment had to start within 8 weeks of surgery. The trial divided the patient population into three different groups. Arm A, or the first group, which received only post-op RT 60 gray in 30 fractions, 5 days a week. Second group received 60 gray in 30 fractions over 6 weeks, same as group 1, but they also received weekly concurrent chemotherapy with cisplatin. And we need to note that the dose of chemotherapy was 30 milligram per meter square. The third group received 60 gray in 30 fractions over 5 weeks. It is important to see that in this third group, the radiation was given 6 days a week, Monday through Saturday. Only Sunday was off. So this group did not receive chemotherapy. So these two groups are considered as intensification of treatment. And the trial divided the population into high-risk population if in presence of T3 or T4 tumor, N2 or N3 disease, and presence of extracapsular extension. The take-home message from the trial was post-op RT should be the standard of care in adequately resected locally advanced oral squamous cell cancer. Intensification is beneficial in high-risk population with multiple risk factors. The study could not clear whether delivering higher dose like 66 gray for margin positive disease or extracapsular extension is beneficial over 60 gray or not. Also, it could not clarify whether a higher dose of cisplatin, which is more or less standard, like 40 milligram per square meter, could result in better outcome or not. Intensification should be standard of care for high-risk population with multiple risk factors. Accelerated radiation, like 6 days per week, can be used in patients who are not suitable for concurrent chemotherapy and or who want to avoid side effects of chemotherapy. Now, is there a dose-response relationship in adjuvant treatment of oral cancer with radiation? So this study by Peters et al. And this shows very beautifully that there definitely exists a dose-response relationship. Any dose beyond 57.6 gray and up to 63 gray gives better outcome than a dose which is less than 57.6 gray. Whether the dose beyond 63 gray gives any additional advantage is not probably that does not exist. So a dose response relationship beyond 63 grade is not appreciated in this article, and a dose below 57.6 gray is inferior. Now, when to start? It's a practical question, and we must know when to start the radiation after surgery. So the post-op radiation must start within 6 weeks from the date of surgery. And of course, the wound has to heal properly. But most of the patients managed properly in a good oncology center, they can, we see that the wound actually heals very nicely within 6 weeks. So starting radiation by end of 6 weeks is of paramount importance. What is the importance of overall treatment time in head and neck cancer? So multiple articles have addressed the issue, and we have seen, and we know now we know that the overall treatment time from the date of surgery should be less than 100 days. And to be more precise, in another article, they have showed that the loco-regional control worsens by 9% with every week's prolongation of overall treatment time. In another article by K.K. Ang, it was shown that the outcome is actually much better if the total time from the date of surgery is 11 weeks or less. And beyond 11 weeks, the outcome actually significantly starts deteriorating. And if we see that the outcome for group where the overall treatment time was more than 13 weeks, it dropped significantly. So more than 6 weeks of interval between surgery and RT was detrimental, and completing the therapy in a cumulative time of more than 13 weeks yielded a significantly lower loco-regional control rate. So we must try to finish the overall treatment by less than 13 weeks time. So if we calculate that way, probably the best outcome will happen if we can start the radiation by end of 4th week or early 5th week, so that by end of radiation, it is 11 weeks or less. Now, regarding this concurrent adjuvant chemotherapy, whether do we need to give a 3-weekly chemotherapy as most of the Western countries are doing, or we can follow a weekly cisplatin regime as we see in most of our centers. So this is an unpublished article, and I thank Professor Atul Sharma, who has allowed me to use this for academic purpose. So he presented this article in abstract form in 2022 ASCO, and he showed that this is a non-inferiority trial, and he showed that weekly cisplatin at a dose of 40 milligram per meter square is non-inferior to 3 weekly cisplatin at 100 milligram per meter square. Now, is there a role of neoadjuvant chemotherapy in oral cancer? The question is, why do we need to give oral cancer? What is the perceived benefit? So the perceived benefit by the surgical community is conversion of borderline resectable or unresectable cancers to resectable cancer. It may make the surgery margin free. It may help in organ preservation. In organ preservation, that means we probably in some patients, mandibulectomy can be avoided, and it might improve the overall survival as well in by taking care of some micrometastatic disease which is not clinically or radiologically detectable. There are very good articles from, again, Tata Memorial Hospital Group, led by Dr. Vijay Patil. An initial study which was published in 2014, they have showed that the benefit of using neoadjuvant chemotherapy is like 43% of the borderline or unresectable patients, they were converted to resectable group. And the overall survival was 19.6 months in NCT group versus 8.1 months in the other group. And in a subsequent publication, which was published in ASCO 2023, they have actually published a huge number of data. So more than 3,000 patients data, mostly for advanced oral cancer. And tongue was, so cheek mucosa was the primary side, followed by tongue. Stage 4A was the most common side, most common stage. And the indication for NACT in this group was edema up to zygoma, involvement of hyoid, and high infratemporal fossa. Most common chemotherapy regime was docetaxel and cisplatin, followed by doci, cis, and 5-FU, and paclitaxel was actually less. And they showed that this 3-drug regime gave best outcome compared to 2-drug regime. And it's very interesting to see that in overall, in the entire group, the median OS was 9 months. The 28.4% of this neoadjuvant chemotherapy group, which were initially unresectable, they were converted to resectable group. And we can see that 8.2% patient, they actually achieved pathological complete remission. So at 10 year, we can see that the survival was 21% in patients who received more than 2-drug regime, and it was almost 22.3% in those who could undergo surgery after NACT. Now, one criticism of this trial, which as a radiation oncology community, we should know that this 28.4% who undergone surgery followed by CTRT, and this 13.1% who undergone definitive CTRT, that makes like 41%. So 59% of these of this entire population who were non-metastatic, they were not offered definitive radiation to begin with. Now that's a debatable question. I am not criticizing this study, but there's a question that whether offering radiation to all these population would have changed something. I do not have the answer. Now, is there any other role of neoadjuvant oral metronomic therapy? So this is a study from South, and they showed that if there is a long waiting, which is a very common situation in our country again, so long waiting for surgery, then the patient can undergo some short duration of oral metronomic chemotherapy before actually going for the surgical resection. And so the authors commented that it's a feasible strategy worth considering in cases where there are prolonged waiting times to surgery. Now, there are a couple of trials which actually explored the options of neoadjuvant chemotherapy, and we can see that these tracks 323 and 324, where 16 to 17% of the population were having oral squamous cell cancer, paradigm and decide. So these are mainly for technically unresectable population, and the technical unresectability criteria I have already discussed. Is there a role of definitive chemoradiation in oral squamous cell carcinoma? So first of all, we need to know that this is not a standard of care in resectable cancer. We must ensure that operable cancer patients are counseled properly for surgical resection. 2 randomized controlled trials actually explored this option, and both of them failed to prove any superiority of definitive chemoradiation in this situation. What are the treatment options for stage 4 tumor or metastatic tumor? So the main purpose of treatment in stage 4 patients are palliation. Overall, the response remains poor in stage 4 oral cancer. Systemic therapy or best supportive care are both options. Immunotherapy of late has shown some promise. Now, another important trial from Dr. Patil's group is using of low-dose immunotherapy, where they have used uh, oral metronomic chemotherapy and nivolumab at a flat dose of 20 milligram every 3 weeks, and they have shown better result compared to oral metronomic chemotherapy alone. Now, recurrence is a very common scenario in oral squamous cell cancer, and there is some significant work done by this Mary group, and they have divided the patients into three classes: class 1, class 2, and class 3. That depends on the interval from the first radiation, resectability at the time of resection, and presence or absence of organ dysfunction. Now, organ dysfunction here means either whether the patient is tube dependent for feeding, or permanently tracheostomized, or there is any risk of aspiration or not. Now, if these things are present, then the patient comes under category 3. So a tumor which has recurred within 2 years' time from the first course of radiation, having organ dysfunction, they are class 3. And if we see the outcome in this category 3 patient are actually very less. Only 17% survive up to 2 years. Now, a disease-free interval of more than 2 years, where the recurrent tumor can be operated, they come under class 1. And here we can see that the 2 year survival is almost 62%, which is decent. The somewhere in between is the class 2, who are like in between. So they do not follow either in category 2 or category 3 or 1. So they are category 2. And we can see that even they also fare well, like almost 40% 2 year survival that we can expect. Now, this is the category 3, where even after the resection of the recurrent tumor, no matter whether we are giving radiation or not, their survival remains poor. So in this situation, probably adding more radiation does not help and does not improve quality of life. And we can probably defer their radiation only for some palliation or symptomatic relief. Now, what are the treatment options at the time of recurrence? So again, there are options of attempt for doing a surgical salvage, further radiation, and in case of in presence of some high risk factors after surgery, and palliative treatment. Re-radiation with definitive intent, again, possibility where the tumor is local, the recurrence is localized without organ. Again, re-radiation can be done. So there are a lot of articles, and re-radiation itself can be a 2-hour talk. So I am not going into the detail. Now, the radiation oncology community, as we treat a lot of recurrences nowadays, because the outcome has definitely improved and patients are surviving more compared to what they used to survive 10, 15 years back. So we are seeing more recurrences. We are treating more recurrences. Now, how the tumor should be, or the volume of radiation should be decided. The gross tumor volume should be controlled properly, and all kind of images, whatever is possible, like MRI, PET scan, should be fused with the planning images, and maximum information about the gross tumor should be addressed. So the gross tumor with a small PTB margin, depending on the institutional setup. And in case of resected tumors, the operated volume with a 1 to 2 centimeter should be treated. It's not important to treat the nodes prophylactically in case of re-irradiation. All these tube techniques, including conformal radiation, IMRT, SBRT, proton therapy, or brachytherapy, have some role, and anything beyond conformal therapy is good for treating recurrent disease. So this is how we can, the modern radiation planning can help in re-radiation. So this patient was initially treated in 2019, who had some high risk factors for which she also received post-op radiation, and both the necks were addressed at that time. She had a recurrence in 2021, for which a second surgery was done at the tongue. And again, she received local radiation because of presence of some high risk factors. After almost 1 year, she had a lower neck failure in the contralateral side, which was surgically salvaged, and she was having extracapsular extension. So considering that there is a long interval of more than 4 years from the primary radiation on the contralateral side, and that the dose of initial radiation was prophylactic, so a full course of adjuvant radiation for the entire neck was planned with a differential dose for site of recurrence and other site. And this patient is now almost 9 months post-radiation without any signs of recurrence as of now. Brachytherapy has a very important role, but the usage is limited. It's a conformal treatment, but the uh, use is limited in selected areas like lip, floor of mouth, buccal mucosa, anterior tongue, where the tumor is very small, like T1 or early T2. And one can use brachytherapy for small tumor as a definitive treatment and as a boost after external beam radiation. So depending on the intent, the dose of brachytherapy can also vary. LDR is now almost obsolete from all centers, but still for historical importance, we need to know that the dose of LDR was 60 to 70 gray, and for boost, it was 20 to 35 gray. Now, when we are converting them to HDR, the dose for radical treatment is 45 to 60 gray, and for boost, it is 21 gray, 3 gray per fraction. This is one such example where brachytherapy was done for a small, well lateralized tongue lesion. And important to know that this, after treating the tongue, the neck was also addressed with external beam radiation with IMRT. So just like in surgical series, we have seen that neck cannot be left untreated. In radiation also, we should probably go with the similar concept where if after treating the primary, one should address the neck as well. Now, SBRT in primary treatment has has not gained any established role as of now. However, SBRT has some role in treating the recurrent disease, and because of its steep dose gradient, one can use SBRT for small, well lateralized recurrences. So I'm repeating, it's a small, well lateralized recurrences, and one must take care of the risk of carotid blowout before planning for SBRT. And if there is such risk, then one must consider for carotid stenting before planning SBRT. So this study actually showed gradients of how the different dose fractions were uh, decided. So they started with 25 gray in 5 fraction, and gradually they escalated those to 44 gray. And they have seen that outcome actually remains meaningful when the dose is at least 40 gray. So 40 gray or more in 5 fraction should be the target. Anything less than that is probably going to be high palliation. So at the end, the take-home message is oral cancer is important cancer in this subcontinent, which is mostly caused by tobacco. Surgery is preferred in operable oral squamous cell cancer. Margin-free surgery and adequate nodal dissection is very important to have optimal oncological outcome. Neoadjuvant therapy in borderline or inoperable patients should be discussed and can be tried because that is showing good outcome. Adjuvant treatment in locally advanced cases or high-risk cases are standard of care, which can include adjuvant radiation or adjuvant chemoradiation. Weekly low-dose cisplatin is accepted and non-inferior to 3-weekly schedule. Palliative systemic therapy in like chemotherapy, immunotherapy, oral metronomic therapy, or total metronomic therapy with immunotherapy is acceptable. Selected patients can merit second surgery and or re-radiation with improved outcome. So with this, I thank you all for your attention. I thank again Dr. Chaturvedi and Dipti ma'am both. And if there is any question, I'm happy to take.
Thank you, Dr. Mondal. I say very nice and crisp presentation and very good for the residents and undergraduates, those who are listening. It's really very nice and eye-opener.
Thank you
And
so much, sir.
but you have given a very nice overview of stage 1 to stage 4 tumors, how we should manage them, and what should be the status after recurrence, because the recurrence is very common, rather re-radiation of oral cancers, because nowadays we are facing the same problem. People are cured for the disease, and after 2, 10, and 15 years later, they are coming with the second, we must consider as second primary or the older tissue which has come up with the recurrence.
This is
So,
very nice comment, sir. I actually
yeah,
agree with this that there was a time when recurrent disease did not have much options, but now definitely we
yeah,
are seeing recurrences because survival has definitely improved. More
yes,
patients, more patients are now being diagnosed with early stage cancers, and they are surviving, and that is why they are having recurrence. And it's good to see that even when they are coming with a recurrent disease, with proper case selection and at a good center, they can be well managed and they can be given a good oncological outcome.
That's really good. Because we have come out with the latest machines for the radiation, and safely they can re-radiate the things.
Yes.
We can deliver higher dose to the recurrent site. So we are inviting questions from our audience. They'll be very happy to answer. It's really nice and very crisp presentation. Consolidation of every surgical, medical, and radiation oncologist.
Thank you so much, sir. I am not a surgeon, but I try to give a kind of overview.
No,
And if
it's
there
an
is any,
overview.
yeah, if there is anything which is not correct, I apologize for that. And if there is a question, please let me know, sir.
Okay.
Yes, Mona Lisa, Clirnet team.
No, ma'am, there are no questions. I
No
believe sir
question.
has beautifully explained everything.
No, it's really
You could
very
also
easy and
understand than with me.
Thank you
If
so much,
she
sir.
can
Thank you so much, ma'am.
understand,
thank you,
then
Dr.
definitely. It's very basic, simply and very elaboratively and informatively. Everything you have told in a crisp and very accurate manner. And hats off to you. Thanks. Thanks. It has been a
Thank you so much,
pleasure
ma'am.
listening to you and our audience too. Thank you, audience, for being such a good listener also. And thanks to the Clirnet team. Yes, Doctor, do you have to say anything?
No, it's all
I'm
he has
really,
already explained.
I'm really thankful to you that you have been consistently doing this academic sessions for a long time now. It's very difficult to maintain, and you have been maintaining this for a long time.
They're trying to do it.
It's
And hats
all
off to
because
you.
of
It's not
you,
easy. It's not
people
easy. I
like you,
understand. It,
who are
you are
in a
taking all
group.
the pain and you are managing everything. It's really hats off to you.
Thank you so much.
We'll try and we'll keep
My
on doing
pleasure.
it.
We'll keep on calling you again and again.
Thank you so much.
Thank you, sir.
Okay. Thank you. Then we'll
Bye.
take your leave. Thank you,
sir.
Clirnet,
Good night,
for your
everyone.
seamless cooperation. Okay. Bye.
So with that, we come to the conclusion, everyone. Thank you so much for letting us host the session today. I hope you all had a seamless and hassle-free experience. So with all your last comment, we are concluding the session over here and really looking forward to hosting all again. Thank you so much and good night to all of you.
Okay.
Night.
Good night, all.